Okay, that's okay. It's 8 o'clock in the morning on the dot, so I think we should start this session. First of all, welcome everybody to this practical ultrasound workshop. Today focusing on lumps and bumps, abdominal and inguinal hernias. Today, the objectives of my lecture will be to learn about the pathology of common abdominal wall and inguinal and femoral hernias, to learn about the ultrasound equipment and optimal examination techniques regarding these topics, to learn about the ultrasound morphology of fixed and sliding hernias, symptomatic and asymptomatic hernias, and finally, to learn about the bowel obstruction and vascular compression of the content of the hernias. First of all, to address the first objective, let me to give you some advice about some useful reference, and I have to say that I've taken some illustration on this wonderful papers, and I recommend you to have a look to these wonderful papers. So, first of all, abdominal hernias, what they are. We define a hernia as a protrusion of a part or structure through the tissues which normally contain it. The key elements of a hernia are the sac, the neck, and the contents. This latter may be most commonly fat and bowel. Less commonly, but we have to take this in mind, that almost or any solid or all of abdominopelvic viscous may be part of the contents of the hernia. Abdominal wall hernias are common disease of the abdomen with a global incidence of about 4–5%, and they represent one of the most common reasons for emergent surgery performed in patients over 50 years old. So actually, they are the second most common indication for surgery after acute appendicitis, both in Europe and United States. Inguinal hernias are the most common, with a prevalence of about 70–75%, followed by femoral 10–15%, umbilical 8%, epigastric and incisional hernia. More or less 50% of hernias are indirect inguinal hernias. Generally there is higher prevalence in males, but however, for anatomical reasons, women are more affected by femoral hernias. The most common cause of hernia in the newborn is congenital malformation, whereas in adults, wall stress, and in elderly, weakness of the abdominal wall. Why abdominal hernias occur? Usually, hernia occurs at sites of weakness in the abdominal wall. Hernia may be congenital, mainly in newborns occurs, like omphalocele, or acquired. In this case, hernia occurs at sites of anatomical weakness, such as umbilicus, linea alba, transversalis fascia, femoral canal, and is often associated with increased pressure in the abdominal cavity due to obesity, chronic cough, straining, pregnancy, ascites, or bladder outlet obstruction, and it's in conjunction with the weakening of abdominal boundaries, for instance, due to aging, trauma, previous surgery. So, where abdominal hernias does occur? We can divide abdominal hernias into external, internal, and diaphragmatic. Today we will focus on external abdominal hernias, and I mean groin hernias, inguinal hernias and femoral hernias, ventral hernias, anterior and lateral, and posterior hernias. So, ventral hernias arise along the linea alba in the anterior part of the abdominal wall. So in this part of the abdominal wall we find the epigastric hernias, paraumbilical hernias, umbilical hernias, and hypogastric hernias. This is the location of ventral hernias. Whereas the lateral abdominal hernias arise in this part of the abdominal wall, and the typical kind of lateral abdominal hernia is the Spigelian hernia. Groin hernias arise in this part of the abdominal wall, and please take note of this red line that represents the inferior epigastric vessels. This is an important anatomical landmark, as we'll learn in a few minutes. We can divide inguinal hernias into indirect and direct. Indirect inguinal hernias arise laterally to the inferior epigastric vessels, whereas direct inguinal hernias arises medially to the inferior epigastric vessels. And then we have femoral hernias that arises below this structure over there. This is the inguinal ligament. So a little bit of anatomy. This is the inguinal ligament. This is the spermatic cord. This is the deep ring of the femoral canal. This is the femoral canal. This is the superficial ring of the femoral canal. This is external, the internal and oblique muscle of the abdomen, and this is the transverse muscle of the abdomen, and this is the rectus abdominis muscle. Oh, we are looking this picture from the front side. Now look it from behind, from the inside of the abdomen. This is the inguinal ligament. This is the femoral artery, and this is the inferior epigastric artery arising from the femoral artery. This is a quite important anatomical landmark. So, look at this triangle formed by the lateral aspect of the rectus abdominis, the medial part of the inguinal ligament, and from the inferior epigastric artery. So this triangle is the Hasselbalch triangle, or inguinal triangle, and direct inguinal hernias passes through this weak zone, weak area of the abdomen, called Hasselbalch triangle. On the contrary, indirect inguinal hernias penetrate to the deep ring of the inguinal canal through the inguinal canal into the scrotum. So two different ways of penetrating this area. And finally, femoral hernias penetrate below the inguinal ligament, whereas both direct and indirect inguinal hernias penetrates above the inguinal ligament. So a little bit of anatomy. So now let us speak about the ultrasound equipment and optimal examination technique. We are talking about really superficial structures, so we need a 10 megahertz probe, or in larger patients we also can use a 7.5 megahertz transducers, and we can start our examination with a patient lying supine, but we can also ask the patient to stand up, and we can also perform our examination with the patient standing. This is useful to elucidate the visualization of the hernia. We can also ask the patient to perform a Valsalva maneuver, so increasing the abdominal pressure and to facilitate the evidentiation of the hernia. So these are the main four position for locating our probe in order to evaluate such area in order to assess the presence of abdominal hernia. Position number 1, 2, 3, and 4. The first position is a transverse scan of the abdomen on the rectus, above the rectus abdominis, and trying to visualize also the inferior epigastrious vessels. These are the inferior epigastric vessels arising from the femoral vessels. So this is the position. This is the position in which we put our probe, and this is the image that we have, a transverse scan. This is the fibers of the rectus abdominis muscle, and these are the inferior epigastric vessels. We can, of course, use color Doppler modules in order to better visualize the inferior epigastric vessels. This is a typical location where Spigelian hernia occurs. So this is a quite good position for evaluating a Spigelian hernia. That is, this is the same position as before. This is the rectus abdominis muscles, the muscle of the lateral wall of the abdomen, and this is the inferior epigastric artery. This is a pre-Valsalva maneuver sonogram. After Valsalva maneuver sonogram, we can evidentiate this part, this fat, preperitoneal fat protruding as hernia between the two muscles. So this is typical location for Spigelian hernia. If we move from this position, position number 1, to position number 2, following the inferior epigastric vessels, so this is the area, we are locating our probe right on the deep ring of the inguinal canal. This is the right location for evaluating an indirect inguinal hernia. So we move down our probe following the rectus abdominis and the inferior epigastric vessels until we'll see this structure, hyperechoic stripe, that is the superior aspect of the inguinal canal, and always use inferior epigastric vessels as landmark for your examination. Again, inferior epigastric vessels, this is a longitudinal oblique scan. This is the deep inguinal ring, and this is the right location for evaluating an indirect inguinal hernia. So let's see this sonogram. We have the inferior epigastric vessels as landmark, and laterally to the inferior epigastric vessels, these structures arising over there, that is an indirect inguinal hernia, lateral to the inferior epigastric vessels that we use as anatomical landmark for our evaluation. Please remember that indirect inguinal hernia usually have a small neck. Again, an indirect inguinal hernia, this is femoral artery, this is the vein, the femoral vein, and this is the epigastric inferior vessel. And again, the hernia arises laterally to the epigastric vessels. And again, note the small neck of the hernia that arises laterally to the inferior epigastric vessel. So, if we move a little bit medial, our probe, we are looking at this area that is the area of the Asaba triangle, and this is the proper location for evaluating a direct inguinal hernia. So if we move slight medial our probe, and again, these are the inferior epigastric vessel, and in this position, medial to these vessels, we have this protruding hernia, medial to the vessels, and please note in this case the large neck of the hernia. Again, femoral artery, femoral vein, inferior epigastric vessels, and medial to these vessels, hernia protruding over this area. Note again the pre-Valsalva and post-Valsalva maneuver it's useful to better evidentiate the hernia. Again, a pre-Valsalva maneuver sonogram and post-Valsalva maneuver sonogram. We have the inferior epigastric artery over there, and medial to the artery, this protruding hernia, a direct inguinal hernia. Please note again the large neck of the hernia. So this is schematic about the inguinal hernias. So femoral vessels, inferior epigastric vessels arising from the femoral vessels. This is the inguinal ligament. This is the rectus abdominis, and this is the inguinal canal with deep ring and superficial ring. This is in this schematic. You can see the three vessels. We put our probe over there, and we see the section of the inferior epigastric vessels, the artery and the two veins, and this is the deep ring of the inguinal canal. If we have direct inguinal hernia, the hernia arises medially to the inferior epigastric vessels. On the contrary, if we have indirect inguinal hernia, the hernia protrudes laterally to the inferior epigastric vessels. So some take-home points about direct and indirect inguinal hernia. We use the inferior epigastric artery as critical anatomical landmark in differentiating those types of hernia. A hernia originating lateral to the inferior epigastric artery is indirect, whereas hernia originating medial to the inferior epigastric vessels is direct. The direct hernia projects through the inguinal triangles, whereas indirect hernia projects through the internal inguinal ring. Therefore, the neck of the direct hernia passes medial to the inferior epigastric artery. The sac of indirect hernia lies within the inguinal canal, so this type of hernia may easily pass through the external inguinal ring and enter the scrotum. And the risk of strangulation in indirect hernia is more than indirect type, because the indirect hernia passes through the internal inguinal ring and have a narrow neck. And the direct hernia usually protrudes through the inguinal triangle without a narrow neck. So, the last type of groin hernia is the femoral hernia, and in this case we have to put our probe inferiorly to the inguinal ligament. So the right position is position 4, inferiorly to the inguinal ligament. This is the oblique view sonogram. This is the inguinal ligament, the artery, the femoral artery, the femoral vein, and we have to put our probe in this position and below the inguinal ligament. Femoral hernia may present with emergencies such as incarceration and strangulation, because this structure, the inguinal ligament, is rigid. If hernia passes below this ligament, may become incarcerated. Femoral hernia most commonly occurs in females, especially older women who have sometimes less bulky musculature and weakness of pelvic floor. And we have sometimes, of course, an inguinal hernia repair as risk factor. Surgery for pure surgery for inguinal hernia repair is a risk factor for occurring of a femoral hernia. Moving below the inguinal ligament, we use another anatomical landmark for evaluating femoral hernia, that is the saphenofemoral junction. This is a femoral artery, femoral vein, and this is the great saphenous vein. The saphenofemoral junction is another anatomical landmark that we use for evaluating femoral hernia. Indeed, this is a pre-Valsalva maneuver sonogram and post-Valsalva maneuver sonogram. This is the femoral vein, and The hernia over there is medial to the femoral vein, so below the inguinal ligament and medial to the femoral vein, but below the inguinal ligament. The inguinal ligament is over there. Again, artery, vein, femoral artery, femoral vein, pre-Valsalva, post-Valsalva maneuver, and after Valsalva maneuver we have a femoral hernia arising medial to the femoral vein. Briefly, some other type of hernia, paraumbilical hernia, usually maybe in adults or in it's usually acquired, so it arises in adult, just above or below the umbilicus, often in obese, multiparous, middle-aged women, and usually we have a neck narrow in this kind of hernia, as we can see in this example. This is the rectus abdominis muscles, and with a short, short neck, we have this paraumbilical hernia. Umbilical hernia may be congenital or acquired. Of course, this in the congenital form is usually encountered in newborns, and this is a hernia in a 4-month-old boy. So in a newborn, the rectus abdominis muscle and hernia arising between the two muscles. And this is an epigastric hernia. Note the small neck of this hernia. And finally, we have incisional hernia. I mean, this kind of hernia arises in people who underwent previous surgery. These are typical location for surgical cuts, bikini cuts, cut on the linea alba or subcostal left region, for instance, for cholecystectomy. And in fact, this is a case of a patient who underwent cholecystectomy, and after cholecystectomy, we have incisional hernia in this location. So let's talk about the morphology and of fixed and sliding hernias. So when a bowel loop is herniated in a sac, the bowel loops can be returned to the proper location in the abdomen, but they can also be fixed in the hernia. And this is an important observation because of the higher risk of obstruction or strangulation when the bowel is incarcerated. So when we perform our examination, we have to look if there are signs of incarceration, strangulation, as we will see in a few minutes. Actually, abdominal hernia may be reducible when it can be replaced completely into the peritoneal cavity, but they can be irreducible when it cannot be returned to the abdomen. Abdominal hernias can be also obstructed if the loop of the bowel becomes non-functioning, even if the blood supply is still patent, is still good, normal. But the abdominal hernia may become strangulated if, in addition to incarceration, there is a compromise of the blood supply, a cutoff of the blood supply. In this case, gangrene of the hernias may occur after time or incarceration. Sliding hernia. What is sliding hernia? A sliding hernia is a protrusion through an abdominal wall of a retroperitoneal organ. The frequency of sliding hernias is about 6–8% of elective inguinal hernias repairs, and sliding hernia is more common in the indirect hernia than in direct hernia. Usually, a portion of the wall of the hernia sac is composed of an organ such as sigmoid colon, urinary bladder, appendix, cecum, uterus, and ovary. For instance, this is a case of the 14 years old girl with a left groin palpable mass suspected for hernia. And when we performed our ultrasound examination, this is the appearance of the mass in the groin region. This inhomogeneous, roundish, mostly hyperechoic lesion in the axial scan with some peripheral vessels. This is a sagittal scan of the same lesion, and in this scan we can notice almost two different portions of this lesion. One area of the lesion is this one over there, inhomogeneous, hyperechoic with some hyperechoic region, and in the caudal part of this lesion we can see these multiple small anechoic areas over there. And this is the MR of the same patient, which also demonstrates in this area a lesion with two different components. One component over there, another area over there with some multiple small cyst-like lesions. Also note some small teeny fluid component in this area. This is a sagittal T2 weight image. And this is the mass, this another slice demonstrating this mass over there. This is the sagittal T2 weighted image without fat saturation. There's an area over there that is hyperintense, and the area becomes hyperintense in this sagittal T2 weighted image with fat saturation. And this lesion shows a contrast enhancement after the gadolinium injection. So this is a mass in this area, and the final diagnosis was left ovary plus teratoma herniated in the inguinal canal. So a sliding hernia in this young girl. In this case it was an indirect hernia. So let's talk briefly about bowel obstruction and vascular compression of the content of the hernias. If we are looking for abdominal hernias, of course we have to search for the contents of the hernias, the location of the hernias, the type of the hernias, the contents of the hernias, fatty tissue, bowel, other organs. But we also have to look for the presence of absence of free fluid in the bowel loop, in the hernial sac, and the presence of fluid in the bowel loop. We have to look to the wall thickness of the herniated bowel loop, the diameter of the bowel in the abdomen, not in the herniated loop, and the presence of the absence of color Doppler signals in the hernial contents, and the presence of absence of peristalsis in the herniated bowel loop. Because all these signs might be useful in order to differentiate between strangulation and incarceration. This is a table showing the frequency of ultrasound signs of incarceration by Rettenbacher, and we can see with the most important sign of incarceration is the presence of free fluid in the hernial sac. Other signs are the thickening of the bowel wall, and especially if the thickness is more than 4 millimeters. So if the wall thickness is above equal or more than 4 millimeters, we talk about wall thickening of the bowel loop. We also can find fluid within the herniated bowel loop. We can also find dilated bowel loops in the abdomen, and we can also switch on our color Doppler or power Doppler module in order to see if there is presence or absence of blood flow within the walls of the bowel loop. And we also can look to peristalsis within the hernia. This is a case of non-incarcerated umbilical hernia in a 77 years old woman with abdominal wall pain. And in this case, it's quite easily to evidentiate this free fluid within the hernia. And in this other scan, this is the free fluid within the hernia and the bowel loop at the neck of the hernia. And we can also see this tiny dot of color in this portion of the wall. In this case, we can assess that we can say that the bowel loop is still viable. There is maintained blood supply to this bowel loop. So color Doppler module is useful to address this issue. The bowel and the fluid collection and the box, the color box demonstrating some spot, some colored spot into the wall of the bowel loop. Another non-incarcerated indirect inguinal hernia in an 83 years old man with scrotal swelling. This ultrasound clearly depicts this bowel loop, and these are the walls of the bowel loop. There is no thickening in this case of the bowel loop, and at color Doppler examination we can see normal blood flow within the herniated loop. Okay, there is some artifact over there, but we have put our scale in a very low level, so 0.06 meters per second. So it's necessary to lower your color Doppler sensitivity scale in order to detect slow flow. And this is the CT scan of the same patient with a inguinal hernia and some bowel loops, but without any sign of bowel compromission. This is on the contrary an incarcerated inguinal hernia in a 58 years old man, and in this case we have the presence of a bowel loop within the hernia with wall thickening, some fluid within the hernia, and free fluid collection, and this important sign of incarceration, and among with the hernia, some fat herniating in the sac. Another case of suspected bowel occlusion in a 64 years old man, and if we look to the abdomen, not to the sac of the hernia, we can see in this case some bowel loop distended with fluid within the loops, so a sign of obstruction. Whereas looking at the groin, we have bilateral hernias with fluid collection, free fluid collection, and fluid within the herniated loops, thickening of the wall of the herniated loops, and CT scan of the same patient demonstrated the same thing with the abdominal loops of bowel dilated with some fluid, air fluid levels, and the hernia, bilateral hernia, right side and left side, with bowels herniated. And another case of right indirect inguinal hernia in a 44 years old woman. These are femoral vessels, inferior epigastric vessels, and lateral to these vessels we have an hernia, and with color Doppler module we can see that we have still flow in the walls of the bowel, in the axial and in the sagittal plane, the same finding. So in this is the bowel, and this colored spot are color flow within the wall. So in conclusion, I think that we can say that clinical examination is the gold standard for diagnosing an abdominal hernia. and where are clear clinical features, no further investigation is required. But in equivocal cases, ultrasound is increasingly used as elective confirmatory modality for abdominal hernias because it's a dynamic, non-invasive tool which does not use ionizing radiation, so it's useful especially in children. And unlike herniography and CT scanning. Of course, CT scanning remains a useful tool in ER department in order to evaluate emergencies and complication of abdominal wall hernia. So I think that I've finished my lecture, and there is time for a question from the audience. Thank you. So, any question from the floor? Please.
You understand the ground for suspected hernias. Which side of the node do you think works best? Often, I think really works very well.
Oh, actually, yeah, especially if you deal with not compliant patients or old patients. So I just ask the patient to blow out, but with the closed mouth. So do this, just in order to be easy. So blow out with, but you cheek. So I see the cheek blow. Yeah. This is my hint for this situation. Quite easy. Otherwise, if the patient is compliant, I have to close the nose, to close to take a deep breath, to close the mouth, and to increase abdominal pressure. But if the patient is compliant, not always it's not always the case. So any other question from the audience? No one. So okay, perfect.
Do you use MRI for inguinal hernias?
Usually not, but in this case we were not confident that there was in the case of the girl we were not confident there was a loop. We didn't think that it was a loop because no peristalsis, no appearance of bowel wall. So we talked with the referring physician, and we put the patient into MR scan, but it's not the routine.
On a couple of occasions I have seen a very small cystic fluid collection just next to the femoral vesicles, and I am told by the surgeons that is herniated fluid only.
Yeah.
But there is no hernia.
Yeah.
Is that
Could be useful.
as well?
Yeah, yes, I think it's possible, especially in men, because sometimes when the testicles goes down into the inguinal canal to the scrotum, towards the scrotum, sometimes the inguinal canal remain patent, and in this case, fluid can go down. So I think it's possible.
Will the fluid come
From the peritoneal cavity
in a man?
in a man, yeah, could be. Any other question? Please.
The 4 millimeter technique, is that applied for small and large bowel holes, or is there any?
Yeah, I think it's better for, it's a good question, I think it's better for small bowel loops that usually are herniated into abdominal hernias, whereas, okay, even, I mean, cecum or, other kind of loops may herniate into the abdominal hernia, but most frequently small bowel. Please.
Do you think it's important to measure the neck?
Yeah, I always measure the neck, because the smallest the neck, the greater the possibility of incarceration. So I always give this information, either performing ultrasound or CT scan. We have time for some other question if you want. Please.
How do you assess the question recurrent hernia after evacuation? Do you use ultrasound or?
No, we can use, actually, ultrasound is an elective technique. So in this case, if we are not in an emergency room, I think the ultrasound should be performed first. Usually you can't see so well the mesh. Depends on the type of the mesh. But as we have demonstrated, we can easily assess the presence or absence of a hernia and fluid collection or whatever. So I think ultrasound should be performed first. If there are no more questions from the floor, I again thank you everybody for your participation. Please don't. I wish to remind you to fill in your evaluation form and to hand it over when leaving the room. Thank you again. Usually it's placed at the end of the, but in this case, yes, yes, this time, you're welcome. Of course.
And several times when I've been looking for care, and we see a lot of the fund coming down when the patient strains, but the vein expands, and it's the same on the other side. Now, I'm not sure whether or not to call that true or not.
Actually, I understand. In this case, there is no recognition of the power loop.
No.
Just probably the
weakness is,
this is an initial stage. Just part protruding, but it's not a treatment. No.
Okay.
No. Some of them are there, some of them. Yeah, the metaphysicians are in the example, whereas the cases are not.
Yeah.
But at the very first of the part of the session, yes, I took on this. Yeah. No, especially from this part. Yeah, there is a one, and I was in the interior part of the rectum, in the interior section, you find this vessel. So start from above and follow it down. This is mine.